and I'm going live right now. And I'm just going to send a quick message out on Twitter, and then we'll start. Hey, for these guys who's just starting to come online, we'll be starting in just a moment. We got everybody here, and we will be going soon. And if you guys, while you're waiting, if you want to go on your Twitter feed or something like that and reshare the live feed, you can. You can go on my page or you can go on ASRA's page and reshare the live feed. All right, we got some comments. And okay. Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, and today we are doing another moderated poster session. Today's topic is going to surround erector spinae blocks because we have so many posters that were submitted in that topic area. We dedicated a whole day to that. And before we get started and talk about the topic and bring our guests on, I want to mention a couple of things. Today would have been the official kickoff day for the ASRA spring meeting, so we're all sort of lamenting the loss of that opportunity today. But I would be remiss in not mentioning a couple of things that was announced over email today. If you're in the ASRA community, you probably got this email. A couple of award winners that I just felt like it was important to kind of highlight their achievement and work. Dr. Guy Weinberg was the recipient of the Gaston Labatt Award this year. And for those of you who don't know, which I can't imagine there's too many of you, he was the creator of the local anesthetic systemic toxicity protocol, specifically focused on lipid emulsion therapy as a rescue agent for local anesthetic toxicity. And this came about during my career as an anesthesiologist, and to see the impact that's had on regional anesthesia it's hard to quantify. Really tremendous work that Dr. Guy Weinberg has done. Super nice guy too, if you ever get a chance to meet him. So we want to recognize Dr. Weinberg and his achievement in winning the Gaston Labatt Award. Second, and this is no order specifically, but Dr. Joseph Neal has received the Distinguished Service Award. Again, it's very hard for me to give any kind of description of his work and do it justice. Dr. Neal has been both a inspiration for me, but also a mentor, and personally helped me with a lot of success in ASRA. And I'll give him credit, when I was putting together the ASRA COAGS app and trying to get some support for producing that through ASRA. I think that Dr. Neal was one of the ones that was visionary enough to see the value of that and supported me early on in making sure that came to reality. So we want to recognize him for the Distinguished Service Award. And then third, Dr. Priyanka Ghosh was named the 2020 Resident Fellow of the Year, and we want to recognize her hard work. I'm sure that we will be seeing a lot of wonderful work from Priyanka for years to come, so we want to recognize her achievements as well. Lastly, I want to mention tomorrow we're going to be going over the Best of Meeting abstracts and the Resident Fellow Travel Award posters. So we're trying very hard to get the authors of those posters to come and present their own work. They've missed their opportunity to present at the meeting, so we want to give them some opportunity to present their work in a forum where a lot of people can hear all the hard work that they did. So look out for that. I think that's going to be a great show tomorrow. Again, 3 p.m. Eastern Time tomorrow, Friday. And then lastly, I want to mention that we are working with ASRA to create ASRA webinars that I think are going to be important to our community. The first one is going to be next Wednesday, April 29th at 7 p.m. Eastern Time. And we're going to have several speakers talking about the clinical practice in the post-COVID-19 era. And so register for that. Go to the link on the ASRA website or through your email, and then participate in that webinar. I think that's going to be really useful. So those are the announcements. I'm going to do a couple of quick introduction pieces of notes. So other than that webinar, we aren't going to talk anymore about COVID-19 today, so you can get that out of your mind and worry. We're not going to stress everybody out about that. Just as a reminder, all these posters are preliminary research and they're presented as abstracts, so they've not gone through full peer review. So take all the information with a grain of salt and your own personal evaluation. If you are putting comments on the side comment field, we encourage that, but be kind in your comments. This is a place for constructive criticism, no role for shaming or badgering. We want to support people in their hard work. And I have no conflicts of interest related to any of these topics today. If you are an author and we've missed an opportunity to connect with you and you'd love to talk about your poster, just send me a little comment in the comment field and I'll figure out a way for you to get on. We've got 2 of them on today, so I'm excited about that, and we'll do them in a row. And then, like I said, tomorrow we're going to have the Best of Meeting abstracts and Resident and Fellow Awards. We're going to be having our guests as Samar Naruz, Sandy Kopp, and Meg Rosenblatt, so that should be a great show tomorrow. Okay, before we get started, I'm going to put all our people up on the screen here. Everybody can wave hi to the crowd. So we've got Vishal Uppal, who has the best Twitter handle of anybody at Ropivacaine. So he had the genius move of picking that name. How are you, Vishal?
Well, thank you.
Yeah.
There's a story behind it, maybe for some other day.
Some other day, yeah. Kijin Chin is coming to us from Toronto. How are you, Kijin?
Doing well. I'm in my scrubs because I'm ready to intubate some COVID patients. Hopefully not.
Yeah, I know. He's on the ready, and so may have to run off at some point. And then Danielle Ludwin's coming to us from New York. Danielle, how are you?
Good, thank you. Happy to be here with you guys today.
Yeah. Well, we're going to jump right in, and we have 2 authors with us, and Sanjeev, I see you on deck, so I'm going to get you on as soon as Bryant gets done. We're going to talk about his poster, and then we'll get you on. So, Bryant, let's bring your poster up. How are you? Welcome, and thanks for joining us.
Yes, thank you for having me, and hello to everyone in the Twitter community.
All right, and let's get your poster up on the screen, and I'm going to get this little banner off of here so we're not hiding any of it. Okay, you want to start presenting, and I'll give your title here. This is the erector spinae plane block and its effects on respiratory status and pain management in rib fracture patients, a randomized controlled trial. This is abstract number 700. And I'm going to, while you're starting to talk about it, I'll post the link to the abstract in the comments field for those who want to follow along. Go ahead, Bryant.
Excellent. So just to give you a little bit of a background, the study was done in Richmond, Virginia, and it's an area that takes care of about 1.2 million people in the metropolitan area. And we do get a lot of rib fracture patients ranging from car accidents, criminal assaults, people fracture their ribs from recreational activities such as yard work or riding their ATV for recreation. And typically an epidural for rib fractures would be a gold standard, but as we're managing trauma patients, anticoagulation is also extremely important. So over the last few years, the erector spinae plane block has become a viable option for offering pain control while minimizing the side effects from other opioids. And the ESP block has developed a pretty good reputation, and we actually did a similar study as a case series last year. We found that in 3 patients that we did, we were able to double their values with incentive spirometry and greatly reduce their pain scores. So this time around, we really wanted to try to assess the true effect of what the erector spinae plane block was doing in a randomized fashion, so that we could isolate things such as coaching, or any other placebo effect that might happen. So the way that we did this was we did randomization via a sealed envelope technique. And one investigator drew up meds in a blinded fashion and then delivered the meds to 2 other investigators, who performed the rectus spinae plain catheter on a patient. We placed nerve catheters on everyone. So we either opened up the space with saline or ropivacaine, depending on which arm they were blinded to. The measured outcomes that we were looking for were pain score before and after the block and incentive spirometry. So pretty simple setup. The results as displayed in the poster, these are only interim results. So, a main criticism that many on Twitter have said is that this is only an N of 4. So there are only 2 people in each group. Our goal is to recruit 24 people, but we felt that maybe interim results were worthy of a discussion at an ASRA meeting. So you can see here that if you compare pain scores between the sham and ropivacaine group, pain scores are not that drastically different between each arm. And you can see with vital capacity as well that before and after, patients do have better respiratory status, but that difference is not seen between the sham block group and the ropivacaine block group. So I did want to discuss a couple of things that we run into with randomized clinical trials is that can be oftentimes very difficult to recruit the right patients and get meaningful data. So at our institution, although we get a lot of rib fracture patients, it is hard to, some barriers that we've run into include staffing with the study, communication issues as none of the investigators are actually part of the primary teams that are taking care of these patients. So we depend on a hospital system to consult the acute pain service when they feel like nerve catheters are appropriate. As far as other issues with recruitment, a lot of times the ESP block has actually gotten such a good reputation that a lot of these patients actually want these blocks up front. We have many people saying, I don't want the chance to be in the sham group, so I just want the real block. I'm in a lot of pain now. Just go ahead and do what you guys do as a standard.
So Brian, this is it's a good, you guys are obviously early on in your recruitment process, so it's hard to interpret the results. Jinn, I'm going to start with you real quick, if you don't mind. Thoughts on this study, and I'm more interested in the study design because I think that it's early to interpret the results. It's hard to know if there's a difference or not, but I appreciate the fact that you guys are doing a sham block as part of your study design. Jinn, any thoughts on this as a study design? I mean, obviously rib fractures are a major area for targeting for ESP blocks.
First, I want to say congratulations to Brian. I think it's unbelievable that you're attempting to do an RCT in trauma, and I appreciate the difficulties involved. And for sure, this is the gold standard, right? You're comparing a sham injection with an active block. I hope you get to your full recruitment because it would be really interesting to see what happens there. It's interesting that you decided that you would stop your analysis just looking at the bolus injections and you're not following it thereafter. I wasn't sure, looking at your protocol, whether you were going to be delivering active infusions after the 45 minutes. That was one question. And the second one I had for you was, how do you account for other injuries that these patients might have when you're analyzing their pain scores? Are they specifically reporting chest pain to you?
Yes, so those are very good questions. So addressing the question of how we're addressing trauma that may be multifactorial, we did want to restrict the time of the study period to 45 minutes, assuming that as one of our inclusion criteria, the patients did have to have a pain score greater than 7. So, we have a lot of rib fracture patients that actually don't really hurt that much. And so we start them off with multimodal analgesia, and usually they do fine. It's only the patients that have severe pain that we do recruit. And yes, the pain scores or the pain had to be reported in the chest wall. The second question about our management of the patients after the 45-minute study period, as a standard, when we initially started this study, we were doing continuous infusions of 0.2% ropivacaine at 10 cc's per hour. About 3 or 4 months ago, we started using intermittent bolus pumps. So the patients were getting an automated bolus of ropivacaine every 4 hours. The IRB did have some concerns with us extending the study beyond 45 minutes because they felt that based on our results from a previous case series that we would be denying patients optimal care if we continue to give them saline.
Danielle, any questions or about this one? We're going to let Bryant go after this question and then get Sanjeev on for the next poster.
Sure. I mean, I think my comments are similar to Jinn's, that as a study design, I think it's really your results are really interesting. We want to see with bigger numbers what they show. So if it does pan out that when you have more patients, the results are similar, makes us really think, again, placebo, like the effective placebo effect and patients feeling like you're doing something that's going to make a difference. So I really want to know how we can help you get more patients to what the results will be.
Sanjeev, go ahead.
Can I ask? Actually, I did this study retrospective, right? We Jinn and me, we published the retrospective refracture patients, and I exactly know what type of problem they are going to face because, as Jinn pointed it out, that doing a randomized trial in this is really, really very, very tough. I think I'll give very credit to them to at least design the study to begin with. I have questioned that, this when you just score on the pain score is, even if it's chest score, if it's a thoracolumbar trauma, so the trauma score by itself, which I ran into my study when we are trying to get the data, the trauma score itself can confound with the pain on the chest wall or that. So I don't know how they're answering just the restricted to trauma or just picking out only 3 patients, 3 rib fracture, no other injuries. Because just picking out 3 rib fracture without any injury is very, very, I think the pain is so small. I don't know. That is what I wanted to ask, how they are validating or how they are choosing their population exactly and randomizing with just the specific, and what is the multimodal regimen they have in place for these patients?
Bryant, go ahead.
Yes, very good question. So our patients do get a multimodal regimen, which includes acetaminophen and gabapentin. Our trauma surgeons will typically escalate to a fentanyl PCA before calling us for evaluation for a nerve catheter. As far as addressing pain scores, I think you're right that a lot of these times patients have injuries in many other places, and so may report a pain score that's severe in one area that's not part of the chest wall. We were hoping that using incentive spirometry as one of our more important outcomes or measures may address the specific effect of the rectus spinae plane block. And Dr. Ludwin, as far as your inquiry about how to recruit more patients, I think that right now the IRB has suspended our recruitment because of COVID-19.
Right.
But I do think that it does require us to be in constant communication with our ICU colleagues. A lot of times at a big medical center like this that's very busy clinically, research studies can go by the wayside. And so if there is a concerted effort to get the numbers, it does seem like that our regional anesthesia community is interested enough in this kind of intervention in trauma patients that it would be worth pursuing.
Vishal had a quick comment before we jump over to Sanjeev's poster. Vishal, go ahead.
Brian, thanks. Amazing work. And as Jinn and Danielle mentioned, hats off to you to take this study forward. And I really love the design. I think it's very important to do the study, and a question of ethics comes, like some of the comments have been like courageous. I think it's actually more ethical to do something like that, which has sham blocks, and is scientifically sound, rather than doing something which is of less quality. You can say that you're actually wasting efforts doing some study which will not convince skeptics like me to buy into it, to do that. So really, really looking forward to the results of your study, and really want to be convinced that ASP works. Thanks.
Brian, you're welcome to hang out for a little bit if you want to, but we're going to start talking about Sanjeev's article, abstract. Thank you so much for joining us, and we wish you the best and stay safe.
Thank you very much. I might join you guys on the live feed here in a bit.
Okay, great. Thanks. All right, Sanjeev, we're going to move over to your poster here. Just so people know, this is abstract number 727. And I'm as you're starting to talk, I'll put the link in the comments field here. Go ahead, you can start. I think you're still muted, Sanjeev. Turn your mute off.
Okay. I don't think I can read it very clearly, but I just want to give you a brief update. You can fill me in. It is a case. It's a trauma case. So this guy came with a closed chest injury to our trauma unit. At the trauma bay, he arrested. So when he arrested, they started doing chest compression and he revived. It's an amazing story, actually. So they started to revive and they broke number of ribs on that, but he survived that. But for the first time, they came back and again went into arrest. So ultimately, he had to be to support mechanical support. He was on ECMO, and with ECMO, they moved into HVICU. He was in HVICU with all the ribs, like 7 or 8 ribs broken, and on ECMO. And he was not, he was cannulated for a long time. During that time, he was on continuous infusion of fentanyl and some other medications. You can see in the graph. But then what happened eventually, the HVICU guys, they consulted us that can you please help out to win this guy, because we are almost ready to extubate or decannulate, and then we would be really struggling to extubate if he cannot, because he still has chest tubes with getting drained from there. So that time we went, and as you know, we are ESP is lucky in that way that we could do it in that stage with INR of 2.8 with patient on ECMO, which was challenging to position, but somehow we have done this before and we have already published on that population before. So we did to manage a ESP on this patient and started the infusion, and 24 to 4, I think within 24 hours he was decannulated and then extubated. And after that, all the infusions were backed up and he went home. And you can see the chest X-ray before and after, and we could see that definitely, I don't know, we cannot judge exactly with the multiple of other stuff involved. He benefited and he has no pain reported. We have talked to him recently. So with the 6 weeks follow-up, we found that he was pain-free and he didn't take he has not become a chronic pain medication like user. That's all I would say. That's all. Yeah.
I'm gonna answer one of the questions that came up in the comments. The question was used unilateral. I think you wrote that you only did left side.
Yes, because the chest, all the ribs are broken in the left side.
Okay. Vishal, you want to start off here? Any comments or questions about this case of using erector spinae block in a ECMO patient?
Well, I think, am I unmuted now or just on mute?
Yeah, you're good.
Okay. Yeah. So I was just wondering, like APS, I was looking through this and APS called you guys on day 3. Is that the time you put the ESP block in, or is it later on you put
the
the block?
the green part. Can you show me the graph? I think that graph says everything. I try to put
Yeah.
in the green part where he was like, yeah, almost day 11. We put the ESP on day 11.
Okay. I just was just a bit confused because you said it was called on day 3.
No. I
No.
think not day 3. I think we were consulted on day 11. He was
Okay.
on ECMO for 11 days.
Okay.
And how long did you run the ESP block for? Like till the end, or?
I think we ran the ESP. It is still there. I think ESP block we started on 10th, early part of the till 17th.
So almost a week on
Yes.
the ESP block.
Yeah.
Yeah,
More like
thanks.
2 weeks. Sanjeev, can I ask you, what do you think you achieved with the ESP block during days 3 to 10, which was the time he was still on ECMO?
Yeah, we did not know. We do not know what we really. We do not know what we achieved. We just wanted to do it before, so that we wanted to decrease the narcotics. That was what initially initiated, right? But the HBICU, they have a different protocol. They did not want to go down. So it was actually as the communication problem. We could not do. We were just like a pain therapist trying to do the pain, but the patient was still on the infusion. So I get exactly what you are coming at the point. We could not see the opiate consumption amount because HbA1c was still patient was intubated, still he was on ECMO. So they were following a protocol. And even though our infusion was going, they did not decrease the infusion before he wakes up. They said, we'll after extubation, we'll see. What they found that he could breathe better. They could see because there's the ventilatory requirement. He was on ventilation, right? So his ventilation requirements was better, which we could not put it in a numerical fashion here. That's why we left it out because I could not document that improvement because it was all like giving feedback to us. So what we saw dramatically improvement was the amount of even though he was on such a huge dose of fentanyl and Presidex, uh, he did not develop really a chronic pain. I was thinking that he will be developing a chronic pain or like some pain afterwards, which he did amazingly well.
With this case and in your experience, because I know you guys do a lot of catheters, have you seen any tachyphylaxis to ESP infusions?
We do. So in fact, it has happened that when many times you can see that it is mainly when we use lidocaine. It has happened couple to more than the ropivacaine, and many times we have done like we use, as you know, that we use intermittent bolus for all our protocols. And with the intermittent bolus, we start with 20 ml every 3 hours. We have changed multiple times to 30 ml 3 hours in the same patients with the same group within like 1 day, 1.5 days. And so I think the amount of requirement goes definitely more, but I would not per se confirm that it is a tachyphylaxis or it is because of something else.
Any other questions for Sanjeev about this one? I think I found it interesting mainly because, the trend of erector spinae block is, even though we haven't gotten full evidence yet, there is a temptation to start expanding it to other use cases because anecdotally we're finding some value. We don't know what it exactly is doing, but we're kind of looking for these opportunities where we had no options before, no good options before.
Raj, I just want to add one thing. When Eugene and Jinn, me and Mauricio, we reported this block, we reported it for something else, and it has come out as something else, right?
Right.
It was almost like we reported for as a rescue block, and I would say that till date, I always say that it's the best rescue block I have ever seen, right? If you can find something better, do it. I'm not saying that it is better than this and it is better than it is smaller. So there was a big discussion on the breast surgery and the ESP block, right? I personally do not do any ESP block for my breast cases, okay? Because I don't feel that that is the optimal block for that patient. But if you do not have anything else and you do not have any other block for a patient and you need to block, I think this is an option where you can use it. And that's how I look at my clinical practice rather than like, oh, it is better than paravertebral, it is little worse than paravertebral. I don't think we should not go to that discussion together, right? But we have been.
Yeah. Well, thank you very much, Sanjeev. I'm so glad you could join us. I think it's when we're talking about ESP block, having you on is kind of I think appropriate, at least if nothing else, to talk about this block. I don't think it's fair to do it without your input. So I really appreciate you coming on.
Thank you, everyone. I think it was very unfortunate that we lost the meeting. It would have been a great meeting. I was looking forward to it,
Yeah.
but you can't beat the nature, right? When nature comes here,
Yeah. We'll be back together again sometime. That's for
Yeah,
sure. We'll be
we
back together sometime.
Thank you again. Thank you very much for all your time.
All right. Thank you, Sanjeev. All right. So I'm going to go to the next poster here. And Nabil's hanging out with us. He's going to be just visiting here in the corner. We've let him talk too much this week already, so he's just going to be watching. All right. So the next poster we're going to be talking about is poster number 598. And I'm going to put the link up here, and I'll do a quick synopsis of this one, and then we can talk about it. And just so you're prepared, Danielle, I'm going to start with you with the questions afterwards. So this one's, since we're talking about rib fractures, this one mentions erector spinae block briefly in the algorithm, but I brought this up because it's a good sort of all-around conversation about rib fractures. This is pain management algorithm for patients with multiple rib fractures. It's coming from UEMC. And what they did was they attempted to create an algorithm for their patients with rib fractures, trying to use data to establish what kinds of metrics are important in a person's injury and their own demographics to determine whether they should have more advanced regional anesthesia versus other just plain multimodal pain control. And what I'll give them credit for is that they've kind of quantified something that we've taught in a qualitative way, at least that I teach in a qualitative way to most of my residents. And I'll zoom in on the details here in a second, but they've taken into account vital capacity, incentive spirometry, age, number of rib fractures, type of rib fractures, and then locations of rib fractures into this algorithm that you have in the middle. They actually calculate what they call a rib fracture score to try to assess whether the patient's injuries and demographics combine to something severe enough to try to do more aggressive management. And they do consider as regional anesthesia options paravertebral block, erector spinae plane block, or serratus anterior plane block, or rib fixation as a surgical approach to reducing pain, depending on how someone falls into those rib fracture scores. So Danielle, I'll start out with you as a attempt to quantify something that we all treat qualitatively. Can we talk a little bit about what this means here?
Well, your comment is similar to my comment. I think they do a really nice job of giving an algorithm with objective criteria for how to guide next steps in taking care of these patients. So I was really impressed with their algorithm. My question from this poster for the authors is, how do you decide then which of these patients gets a paravertebral, erector, or a serratus block? So that would be my question to them. I'm not sure if our panel wants to answer and what they do in their own practices, but I thought it was a really nice framework of how to approach these patients, and seems with nice quantitative ways of thinking about it. I agree with that.
Vishal, any thoughts on this one? And I don't know how many rib fracture patients you take care of on a regular basis, so I don't know how you handle that in your place.
Well, it's interesting because we were trying to set up a protocol, and our surgeons are really keen on actually assessing them early for surgical fixation, some of the enthusiastic surgeons. Reading this poster, I think the best one when I was trying to look at was the reference the authors have given the first one, which actually has a very good flowchart as well in it. So it's interesting to compare what different institutes have the protocol with. Yeah, it's interesting because we normally don't use vital capacity. We don't measure it. We just more assess it clinically if a patient can take a deep breath or not. And honestly, we don't actually jump on gabapentin, lidocaine, and ice packs, but we do use physio for these patients. And if there are multiple bilateral fractures, we also like to think about epidural, which I thought was missing in the flowchart. You know, epidural
Yeah, I
is
was
probably
surprised by that too. I didn't know how they fit epidural into this algorithm. But
yeah, and they do say ketamine, and we usually try to reserve that again for more opiate tolerant patients. So gabapentin, ketamine, they still have some potential to cause some respiratory depression, sedation. So we try to reserve it for later on, and also I hope they mean catheters, not just single shot blocks, because the single shot blocks are going to be wearing off very quickly. And our approach is, if we can do a paravertebral, we do a paravertebral. But obviously, if there is coagulation issues and things like that, we go to one of these approaches. But I have been a little disappointed with other approaches. The best results in my hand is still with paravertebral.
Kijin, any thoughts on that? And just a comment here from Mornay Wolmerans. He says that clinician expertise and coagulation are the main reasons for different choice of block. So that's how he's kind of separating out the different details of which block to choose for those patients.
Yeah, I mean, from my perspective, I would echo Danielle's comment that, one of the nice things about this is that they've laid out a very structured pathway for people to follow, and that should be the way. I mean, I think there should be an escalation in that you should do what is most appropriate for the given patient with following these guidelines. And again, there are different options you can use, and it is probably no doubt that if you can do an epidural, you can do a paravertebral, that is going to be the most effective. Probably no one would challenge that if you can pull that off safely. You're just putting local anesthetic where it matters most. But it's always good to have the other options, because as we see in multiple settings, it's difficult or contraindicated to do those techniques. And as Morley says, you've got to look at the practitioners that you have available. So I know, for example, in the UK, a lot of patients don't get any blocks at all because, especially in some of the small hospitals, they don't have the pool of practitioners who are comfortable doing paravertebrals, and so they do nothing. And I'm aware of quite a few sites that have successfully instituted an ESP block or a serratus anterior block service, and patients are benefiting from that point of view. But, if you have 100 Vishals, that would be the ideal.
It's also a discussion with the patient as well. What kind of risks is patient? A lot of times, these patients in our setup have chest tubes already. So it's the best time for our residents and fellows to learn these paravertebral blocks, because the risk of pneumothorax is almost non-existent in these patients, although some of them are in ICU, and performing these blocks in ICU is more a challenge. So either to expedite extubation or to actually prevent intubation is my approach using regional techniques.
Let me go jump to the next poster, because it's kind of related to the same sort of thing with rib fractures. So this is poster 893, and I just put the link in the comments field. This one's entitled Erector Spinae Plane Block for Analgesia and Better Pulmonary Function in Patients with Multiple Rib Fractures. So another study, this one's coming from All India Institute of Medical Sciences. And this one, they did 10 patients, pretty wide range of ages, between 18 to 70 years of age, who had pain from rib fractures. And they looked at patients who had at least 2 ribs broken. and they put in erector spinae catheters for pain control with continuous infusions, measured some of their vital signs, measured their pain scores, and in this situation, they noticed a significant drop-off in both pain at rest and pain with movement and stable vital signs, although they didn't have a control in this study, so it's hard to compare against something else. They just noticed a clinically relevant reduction in pain and with those metrics. And so, again, a preliminary study, to say the least, showing the value of continuous erector spinae catheters to facilitating some of the goals of patients with rib fractures. Vishal, why don't you pick up from that one as well? Just start from there. And again, looking at a little bit more patients, not a case report, small case series.
Yeah, the first thing which came to my mind is it is a prospective observational study, and I didn't see any REB or consent in the poster, which worries me sometimes. But overall, a very well written study and a fairly impressive improvement with the techniques. So, but obviously, we have to keep a risk of bias. It's in an observational study, and if suppose we imagine that they didn't get so much impressive results, they would probably not be sending the poster. So that publication bias comes into play as well. But yeah, overall a good study, I would say.
Danielle, any thoughts on this one?
I mean, just, it was if I recall, it was a sample size of 10 patients ranging from ASA 1 to 4, ages 18 to 70. So I think it's a small representation, but I'm glad that they shared their results.
And Kijin, let me ask you a question real quick. So we've tried putting catheters in patients with rib fractures, and we find that we get a tremendous benefit in that first 24 hours, and then the benefit tails off. So, I mean, in this one, they're seeing a stable benefit even 3 or 4 days later. I have not had that kind of result for my ESP catheters. Have you guys had a similar experience, or where you have a rebound in pain after 24 hours?
Yeah, I have the same observation about the results there. That graph, it's kind of unusual to me that there is this gradual improvement ongoing between sort of 1 hour to 48 hours when it sort of reaches its plateau, which is peculiar because usually you'd expect that it would drop straight down. So I'm not quite sure why it continues. The pain scores continue to decrease over sort of the 6, 12, 24-hour period. I mean, I think it's very hard to extrapolate from this study because we don't know a lot about the use of other analgesics. We don't know about the injuries. Just a note about the methods. It's not clear there, but I think that when they talk about the 18 to 70 years old and ASA 1 to 4, I suspect that's inclusion criteria and not actually demographic data on the actual patients that were included.
I read that.
I suspect that. But yeah, I mean, I would agree, and I think Sanjeev alluded to this. There seems to be this slight sort of bounce up or tachyphylaxis that tends to happen. Some of that may be due to migration of catheters as well. So this graph doesn't quite correlate with that experience.
Yeah. And there's a comment here from Hari Kalagara said that which to prefer, ESP or serratus plane blocks. I generally tend to prefer ESP blocks, in my opinion. I think that you get a better coverage of that dorsal ramus, and for some people, there's significant back discomfort too with these rib fractures, and I feel like that helps better. Kijin, any thoughts on that?
I think you have to look at as you say where the sources of pain are. I mean, if they've got even soft tissue trauma to the back, then the larger area you can cover, the better. Having said that, I've not done as many serratuses, so I can't really comment. But the evidence for the serratus working is certainly there, and putting a catheter and local anesthetic on top of the rib. Based on some other studies that have been done by surgically inserted catheters using the same technique, I don't see any reason why that wouldn't work. And if that's feasible, more feasible at the time in your patient, then go for it. But I think you're right. We forget that there's bruising and pain from other sites, so perhaps trying to cover it posteriorly is not a bad idea.
Yeah.
And then you can always do this hybrid approach, which has been suggested. So you can always go in wanting to do a paravertebral, and if imaging's looking bad and whatever, it's very easy to sort of bail right there and then and say, you know what, we'll just do an ESP instead. So that's another way to approach this.
Yeah, Mornay says that he prefers the serratus when he can't turn the patient for some reason, and so that gives him an option at that point. Let me move on to the next poster here. This is poster number 604, and I'm going to put the link up here in the notes and throw the poster up on the screen. And so this is erector spinae plane analgesia, an advantageous technique for the trauma patient with gunshot to the chest. So again, we're still in the chest. We're still talking about injury and pain for breathing and those kinds of things. This is coming from University of Cincinnati, and we have. This is a case report of a 29-year-old woman who was shot, had a gunshot wound to the right chest, had a hemopneumothorax, I presume a chest tube, but they also had a IVC injury. So there was an anticoagulation concern post-operatively where they couldn't perform an epidural for this patient. And so they chose to place a ESP block at T6 with a catheter placement. And I think they ran it for a few days. They just kind of compared her morphine requirements before and after the block and noticed a per day reduction in morphine equivalents from 62.5 to 5. So almost a 60 milligram equivalent drop in morphine equivalents, as well as a complementary drop in pain scores and greater participation in pulmonary and physical therapy. So again, case report, trauma patient. Danielle, I don't know if you guys get a lot of gunshot wounds there. We do seem to get those every now and then. It seems to me in those cases, the chest tube and then obviously the thoracotomy is more of a problem than the original gunshot wound itself.
So actually, we are not a major trauma center, so we see very few gunshot patients.
And do you guys see a lot of patients with chest tubes that you run into anticoagulation issues with?
Yeah, chest tubes for our thoracic cases. But typically, it depends. Those patients sometimes will get epidurals depending on, what the surgical case is. So our thoracic surgeons are still on board for epidurals in certain situations and will modify anticoagulation for those patients.
I think if I can chime in, I think the thrust of this article was, this patient was on anticoagulation because they'd had an IVC repair, and they needed that to prevent sort of postoperative thrombosis. So I think it's the gunshot wound sort of what led to it, but I think ultimately this is an illustration of what you can do in somebody who's anticoagulated, which might rule out a thoracic epidural. But if I can ask Vishal, would you do paravertebrals in somebody who was on a low molecular weight heparin? Or any other sort of abnormal coagulation status?
Yeah, no, that this question comes to me quite often, actually. I basically treat paravertebral catheters like an epidural because there is a chance that the paravertebral catheter can go into the epidural space. Having said that, single shots with ultrasound is slightly different. My chances, and still a deep block. So it's a little relaxed with that. I still try to avoid it. What we get a lot of time here in our institute is surgeon placed paravertebrals. And they're pretty low risk. So if you're removing them, I don't worry too much about low molecular weight heparin for those ones. Would you agree with that, Jinn?
Yeah, I think so because, looking at the literature, certainly vascular puncture is reported with paravertebral blocks, and you are technically close to spinal arteries and veins that come out in that area.
Yeah.
And
I
as you
totally
pointed
agree.
out, there's not much point in doing a single shot block either for any sort of trauma or persistent thoracic pain. So you're kind of looking at doing a catheter if you're going to do a paravertebral, right?
Yeah. So the
So I
main
think
main
this is where
advantage.
this is where serratus and ESP probably have a clear role.
For anticoagulated patients. But if you're comparing epidural versus paravertebral, I think the main advantage paravertebral give over epidural is less hemodynamic upset. But for anticoagulated patients, obviously, that's the best choice. I do have a question for you. Like this straight case report, they did the erector spinae block in lateral position. My usual approach is sit them up, and it's easier to do it, especially if the patient is extubated. Do you have any thoughts on that?
I don't particularly find doing a lateral position difficult. This is what I often do, particularly for rescue blocks in PACU. Especially if you're and if you want to do a bilateral too, even the dependent side, if you turn them into more like a Sims position than a lateral position, you can usually get to both sides quite effectively. So I don't particularly see it as an issue.
Vishal, we routinely, I've done it sitting. I prefer sitting, but we've done many of our trauma patients lateral, especially if they're intubated. Some of them, they just physically, we can't sit them up. They're hurting too bad. We can barely get them on their side, let alone trying to get them sitting. So I do them lateral, bilateral, lateral if I need to. And then, of course, prone when that's an opportunity to, done it prone, which is actually really nice to do them prone. But that's not a luxury we get very often. But as far as the anticoagulation question, I can tell you from personal experience doing a paravertebral block, taking the stylet out of the needle and having bright red blood squirting back at me through that paravertebral needle. That one experience is like, okay, I'm not doing this in anticoagulated patients, because if I start a bleed there in an anticoagulated patient, I have no way of controlling that whatsoever, except short of having somebody go in there and cut down to the paravertebral space. So, I'm a firm believer that that's a deep block, and I don't do it in anticoagulated people.
Yeah, no, anticoagulation is different, and prophylactic low molecular weight is different. Like you give 12 hours, you can do paravertebral epidural after 12 hours of low
That I
molecular
agree
weight.
with. Yeah, I follow whatever rules the epidural rules.
Absolutely, yeah.
Danielle, any other thoughts on this one? I'm going to move on to the next poster here.
I agree. I tend to be conservative in my approach to things. So unless it was an extreme benefit risk situation, I'd like to treat paravertebral as a deep block, similar criteria to neuraxial.
Yeah. We have a guest in Nabil's window here. There's Vina Graf is hidden behind that mask and glasses. So she's waving hi. Good to see you, Vina.
Good to see you guys. And nice
I
to meet
did
you.
recognize her.
This is a
I don't wave
This is 6 feet away, by the way.
This is, yeah.
It's all about perspective.
Exactly.
Yeah. Nabil, I think I'm getting a lot of echo from your mic. You may have to mute it again. Okay. We're going to quickly talk about this one. We're just going to briefly mention. This is poster 1135. This is from University of California, San Diego. Erector spinae plane versus, let me put it on the screen. Erector spinae plane versus paravertebral blocks for post-op analgesia after breast surgery. I think since this was submitted, I think Ki-Jin mentioned that this has actually already been published, so it's probably better to go look at the published version of this. The main point of this study was they compared erector spinae blocks against paravertebral blocks for a few different types of breast operations: lumpectomy with axillary lymph node dissection, biopsy, breast reconstruction with implant placement, and breast reduction surgery. And they did 100 patients, 50% ESP, 50% paravertebral. The way they interpreted the results was they showed that the paravertebral blocks had lower pain scores, which was significant, and lower opioid consumption, which was significant. However, and I'll open this up to discussion, My interpretation is that both of them had pretty low scores to begin with, and that it seems like both of them are reasonable options in this patient population. Kijin, you want to jump in real quick and start on that one, because we were talking about that earlier.
Yeah. So as Raj has pointed out, this paper is available online, as is a letter that I wrote to comment on some of the points in the actual paper itself. It's true that by definition, the opioid consumption was higher in the ESP group and did not meet their defined non-inferiority criteria. But the paper is quite interesting because they go on to look at opioid consumption after PACU discharge and on postoperative day one. And there, the doses that were used of oxycodone were essentially the same. So really, when it comes to the paravertebral appearing to be superior, it really only applied, as far as I could see, to the PACU period. And thereafter, there was no difference in pain scores or opioid use. What you can clearly see is that the ESP was much easier to perform. And be that as it may, in fairness, they did a dual injection paravertebral block. So it works both ways. That you could say that's why the paravertebral block took longer to perform. I mean, two injection paravertebral in 4 minutes is actually pretty impressive. But you're also then comparing a single injection ESP versus a 2-injection paravertebral, and the fact that, when you look at the analgesic outcomes going to postoperative day 1 and 2, and they're pretty much the same, then it really does say, why would you not go with the technically simpler technique? And that's really the point I was trying to make in the letter that I've written.
We have a question from Amina, and she is, what is the site of injection? Was it the same for both? And I think they mentioned in the poster it's between T2 through T5, but they are doing a double injection technique for the paravertebral instead of a single injection technique. I also thought it was kind of interesting that they've got a mixture of unilateral and bilateral cases here. So I don't know how you lump all of that together into the same assessment. That's a little bit tricky to do. But again, I think what we're coming to, and I think the consensus that I'm hearing from a lot of people in general, not just today, is that these are tools in our tool belt. And if, depending on your expertise and your comfort level, all of them are better than nothing, trying to differentiate which one's better than each other is pretty hard to do. And it's the little details are becoming difficult to distinguish between them. Vishal, any thoughts on this one before we move on to the next one?
Yes, I would love to. First of all, anyone who does RCT, I really, really appreciate them. With the efforts involved in doing a RCT with 100 patients is not easy. The second thing I wanted to say is the non-inferiority design. And a lot of people are actually very skeptical of non-inferiority design. People say that, oh, why should we but it's a fact that we have got to that stage in anesthesia where we have got treatments which are pretty effective, So we are looking for things like that, which is ESP, which is easier to perform and maybe non-inferior to paravertebral. At the same time, being devil's advocate, I would say, is a lot of my surgeons even say that don't even bother performing paravertebral or erector spinae for breast surgery because they don't have that much pain, which I don't 100% agree with. But in my setup, it's just easier for me to do PEX blocks. Just give a GA, and when the surgeons are prepping for breast surgery, I can just do a PEX block, just standing at the head and having the ultrasound there. So but hats off for doing any RCTs. Whichever way you interpret, the data is data, and it's there for people to look at, and it's valid data.
Danielle, any thoughts before we jump to the next one? I'm going to get the next poster teed up here, which is 682 for those of you who are interested. And I'll put the link here in a second, but go ahead.
No, I'm good, thanks.
Yeah, so this one, one of the things I wanted to talk about is this sort of, as Sanjeev mentioned earlier, that he, a lot of the description early on was about something, and then now it's become so much else. And one of the things that it's become is moving up from away from the thorax and moving up and down into the cervical and lumbar regions. And so there's a couple of abstracts on lumbar erector spinae blocks, which I thought were an interesting conversation to have because I personally have not done any lumbar ones. This first one comes from the Mayo Clinic in Arizona, and it is evaluating the extent of lumbar erector spinae plane block and anatomical study. So leaving aside the criticisms that have been already published about the value of dye spread in cadaver models for fascial plane blocks, we can talk about that in a minute. This was a dye study in the lumbar region where they were assessing the distribution of dye in, I think they used 5 different cadavers. They were doing both left and right side separately and tried to see how far dye injectate went when they did a lumbar erector spinae block. The volume that they used was 20 milliliters of methylene blue, and then they dissected out the cadavers. 2 things of note: they did not see any contralateral spread on any of the injections. Secondly, they saw spread only up to about L2 was the highest, sometimes only up to L3, did not extend below L5, and they saw no spread into the ventral rami or the dorsal root ganglion. So, Vishal, you're our erector spinae skeptic here. Let me just start with you briefly. Do you think a lumbar erector spinae block has any role whatsoever? And what do you think of this dye study?
Yeah, let me unmute myself. As I believe that every block has some role. I can say lumbar erector spinae doesn't have. But having done a few cadaver studies with methylene blue, when my problem was whenever we dissect, the dye spreads everywhere. So I don't know how much to interpret, and considering that there was a limited spread, which confirms what most of us feel, and it's an evolving area as to how erector spinae works, and possibly, as they suggested, lateral spread to the nerves is probably one of the mechanisms. So it adds something, but obviously still, yeah.
Danielle, do you have any use for a lumbar erector spinae block, or do you see a case for that?
In our own practice, typically we're not doing lumbar erector spinae. I think it's technically a bit more challenging, but other people in their respective practices may find more use for it. We do a lot more quadratus lumborum now for surgeries in the lumbar region.
And you find those to be useful?
We have found good success in using them in our patient populations. Again, I think it depends. What are you comparing it to? So, I think it depends. If you have a practice where you do a lot of epidurals, then I think epidurals really can be the gold standard, but they have a different side effect profile. In our practice, we are using more tap blocks and have converted more frequently to quadratus lumborum and have had better results. So I think it's really important what's your patient population, what's your standard of how you typically do it, and what are you comparing? Apples to apples, apples to oranges, apples to spinach. I mean, it could be very different depending what you're talking about.
Apples to spinach is an interesting comparison.
Right?
Yeah,
Can I say something?
Yeah, go ahead, Kijin.
So I think when you look at what people are using the lumbar ESP for clinically, there's 2 main areas, right? One is in spine surgery, and I can talk about that a little bit. And I think we actually have
That's the next poster.
A paper.
Yeah, I'm going to pull that up here.
The other one where it's coming up is people are using it for lower limb applications. It seems to be mostly proximal lower limb hip surgery. And I think there's a paper out of Stanford that we're going to be talking about. But so people aren't actually using lumbar ESPs for lower abdominal work. I think when you're trying to compare a quadratus lumborum against an ESP, you're probably talking about low thoracic ESPs. ESPs done at a sort of T9, T10 level to try and cover those particular spinal nerves. So it is interesting that there was no evidence of spread apparently to the lumbar plexus or the psoas compartment, which is how one might account for some of the benefit that people are reporting with hip and with really hip type applications. of course, you should remember that, people should remember that there is some L1 dorsal rami contribution to incisions over the hip, particularly in the sort of more proximal incisions, and that may be one factor why this works and why things like a quadratus lumborum 2-block or a posterior quadratus lumborum have also worked for hip surgery. But there is reasonable evidence from some case reports that you can get spread to the lumbar plexus. So that would be one thing I would sort of be cautious about, because depending on whether that's your therapeutic effect or a side effect, you may not want to see that in, say, spine surgery. So personally, I do a lot of paraspinal blocks for lumbar spine surgery, but I don't do proper ESPs where I'm injecting on the transverse process, and I'm doing more thoracolumbar interfascial plane blocks because I don't want to have any chance of spread to ventral rami or the lumbar plexus and cause problems with lower limb weakness or numbness.
So I'll throw a question out that Morne put on here is, what's the difference between a posterior quadratus lumborum block at L2 and a erector spinae block at L2? I would argue that's the same space, just 1 millimeter or 2 millimeters lateral in one versus the other. Probably not that really different of a block. And so it's funny that one we consider having ventral rami spread and one we consider maybe not having ventral rami spread, and we can sit here and argue which one is which on any given day. So, but I'm going to pull up the next poster here, which was related to your comment. This is 1048, and the link is going in the comments for those who want it there. This one is from University of California, San Francisco, and it's entitled Bilateral Lumbar Erector Spinae Plane Blocks for Postoperative Pain Control in Lumbar Spine Surgery. And this is a retrospective case control evaluation. I think they looked at, I'm not seeing it off the top of my head how many patients they looked at here, but they were doing a T12 erector spinae block in bilateral sides from cephalad to caudad with 40 mLs of ropivacaine, 0.35%, 20 mLs on each side, while the patient was asleep in prone position. And they were looking at pain scores, opioid consumption, and other non-opioid pain medications that the patients received. What I found interesting is that I've always struggled about how to do a block for a lumbar spine surgery because they did the block before the surgery, it sounds like, and then they looked at the scores afterwards, and I'll zoom in on the poster. I realized I didn't put the poster up on the screen. I'll zoom in on some of these graphs here, but their description of their results is that they saw a reduction in pain scores that was significant, and a reduction in opioid consumption. Danielle, did you look at this one about the spine cases? I honestly have not done any blocks for spines. I've always tried to figure out what block to do and what might actually be useful.
Yeah,
I think,
sorry.
yeah, there you go.
Right. Yes, I did look at the study. In our current practice, we are not using blocks for spine surgery, so I don't know if someone else on our panel wants to comment on this one.
Jinn, how about you? You said you do some sort of paraspinal blocks.
Yep. So for all my cases, for major open spines, I will do, as I said, I lean towards ESP blocks for anything in the sort of thoracic spine area, and in the lumbar spine area, while colleagues of mine like Josh Melvin in Sacramento are big fans of sort of doing T11, T12 ESPs to cover the lumbar spine. If I'm getting down to the L4, L5 level, I like to do thoracolumbar interfascial plane blocks. And I've had some very, very good clinical success with them. And, I do them preoperatively exactly like these investigators have done a lot of the time, just because they're flip prone. We can't always get them into our block room ahead of time because our block room's full of other patients. But I found that if you do them after they've been induced and turned prone, it's quite quick, it's quite easy, ergonomically it's great. And I actually use a mixture of lidocaine and bupivacaine, and the reason I add the lidocaine is I actually want a quick onset because the interval to incision when you do it this way is often under 20 minutes. And when I haven't used lidocaine, patients are often responding to incision. When I do use lidocaine, they are often absolutely stable at incision. Now, I think that you have to combine that block with, especially for the sort of very major work, you have to combine it with other coanalgesics. And I see here that the authors did use a variety of other agents. Ketamine, although only in 40 to 50%. I use a multimodal anesthetic regimen, and I have to say that patients wake up much more comfortable than they would have been without the blocks. And when you're doing, like the other day, I did a T7 to L3 decompression infusion, and he took 3 milligrams of hydromorphone and was absolutely comfortable off the PCA by the next day. It's things like that that make me believe in the utility of the blocks. But it's not going to be something that allows you always to completely eliminate opioids. But we've seen that clearly you're going to get dorsal rami coverage with an ESP block or a thoracolumbar interfascial plane block. So I think it's actually a no-brainer. And there's definitely this preemptive effect. I mean, I know preemptive blocks are kind of like controversial. Right. But the way I see it, there's a clear benefit. And there are actually quite a number of studies that have come out that mirror, actually have results that are a little bit more impressive than this one. So I think there's something there, and we should see more and more studies coming out in the future.
Vishal, Hari asked a question about neuromonitoring. So do you think there's any, I don't know if you've had any experience with this or not, but do you think there's any concerns about neuromonitoring by the surgeons during spine surgery? I would imagine that most of the neuromonitoring is related to the spinal cord, spinal thalamic tracts, and wouldn't be affected by any kind of block at the external part of the spine. But I don't know if you have any exposure to that. My big question about this, and I don't know if anybody can answer, is isn't the surgeon just sucking up all this stuff when they dissect down there anyway? And how much of that effect is happening? Vishal, you want to try to take a stab at that? You're still muted, by the way.
So it looks like our surgeons are the same as yours. They're more worried about, it's not about whether they'll get analgesia or not, because they're doing so much suctioning. It's also like, if we get some weakness, it just confuses them. Is it due to the local anesthetic we've injected? They routinely actually inject local anesthetic in the skin. But obviously that doesn't give any preemptive effect, which Jinn was talking about. But at the same time, they are pretty liberal with multimodal analgesia. I noticed in this case report, they didn't use any non-steroidals. But our surgeons are we usually check with them before giving, but they're pretty okay with Celebrex, especially, which has very little effect on platelet function. So we usually don't do any blocks for these type of patients.
Well, I'm going to finish.
Vishal, I'll just quickly say that it's exactly right. Same question has occurred to me, like when they start buzzing and scraping off everything and washing out the local. But I will tell you that if you've had enough time for that local anesthetic to work, and that comes back to the addition of lidocaine to the mixture that I use when the onset time isn't longer than 20-30 minutes, the block that sets up seems to be enough. You don't need to have that depot sitting there to have the benefit.
That's interesting. I'm going to put the last poster up because we've gone pretty long today, so we'll finish off with this last one. This is poster number 774, and I'm putting the link up here. And this is another one where people are looking at erector spinae blocks in the lower part of the body. This is from our friends at Stanford and the VA Palo Alto. Continuous erector spinae plane blocks are superior to fascia iliaca catheters in promoting ambulation after hip arthroplasty. So I think most of us deal with hip arthroplasty patients. And in this one, they are describing, I think they had 88 patients in their study, 43 that had fascia iliaca catheters, 45 that had ESP catheters. The ESP group, they saw that their primary metric that they felt like was significant in this situation was the time or the distance of walking during physical therapy. So they showed I'm going to try to get the exact numbers here. The ESP group had on 2-day ambulation distance was 68.6 meters versus 46.6 meters in the fascia iliaca group. And that was significant in their analysis. Pain scores were overall pretty much the same across the board. So another indication, total hip arthroplasty, their main point in this was that with the fascia iliaca block, you could still potentially cause some weakness in the leg. And the erector spinae block sort of provides that analgesia to those upper lumbar regions without causing that weakness. Danielle, I'll start with you. This is another one that I'm not sure what problem it's fixing. We don't routinely do fascia iliaca catheters for our total hips, but they're looking at an outcome measure of ambulation as their primary metric, which is an interesting move away from just pain scores and opioids.
So literally, it is a move. So I like that they looked at ambulation. I think that's a really important endpoint for our patients, and especially as we move more towards outpatient joint replacements in the lower extremity. I think the ability to ambulate is a super important metric, and not only morphine equivalents and what people are using. So I think that's very interesting. Would be really interesting if this study compared their typical regimen with fascia iliaca catheters, erector spinae catheters versus just the other interventions that they do, but no catheters, just to get a sense of how far those patients walk. That would be interesting to look at. But I do think ambulation is an important endpoint, and I think a lot of studies do look at that. But I think it's an important one for us to look at. I was interested, they did say that postoperatively for these patients, they do cryotherapy. I was curious if the authors were on to ask them a little bit more about that. But overall, I thought it was a very interesting study, and they saw significant differences between the two groups.
Yeah, I didn't know if they meant like just ice packs or they meant like cryotherapy,
like
cryo nerve therapy. I don't think they're doing cryo nerve therapy. I'm guessing they just mean cold. Vishal, any thoughts on this one? There's so many blocks for the hip. Mornay mentions Peng block, fascia iliaca blocks. There's, we used to do femoral nerve blocks, lumbar plexus blocks. I mean, it seems like everybody's trying to fix the hip. Any thoughts on the ESP block on this?
Well, I totally 100% agree with Daniel, and we do the same. We don't do any blocks, and they seem to ambulate fine, So I would have loved to see no blocks, especially with catheters. Single shot is different. Catheters does restrict you. You are attached to pump. It delays your mobilization. So I don't know. I don't have too much to say apart from what Daniel's already said.
Yeah, Ki-Jin, you have any final thoughts on this one?
So I think people don't appreciate how heterogeneous hip surgery is. The issues in hip fracture repair depends on the type of surgery. They're different from primary total hip arthroplasties. It depends on the approach that you use. And hip arthroscopy is completely different. And I think people also maybe don't appreciate how different the sources of pain can be, right? It's not just the bone, it's not just the joint, it's muscles and it's skin. Just to reflect very quickly back to the sort of spine thing, the surgeons infiltrate local anesthetic to the skin, but most of the pain in back surgery is from the muscles. And the same thing with hip surgery. A lot of times, even after you fix a patient's broken hip, they have a lot of muscle spasm thereafter. But having said all of that, I completely agree with Danielle. Over here, our total hips do very, very well with just local infiltration analgesia. And even before we started doing that, we always knew that they did very, very well compared to total knees. They didn't require any blocks. So in our setting, we don't see a huge push to have blocks done. I will say that I do know that these authors have previously published their experience with the continuous fascia iliaca blocks, and I believe it was versus no block. And it showed that the fascia iliaca was beneficial in terms of analgesia and motor sparing, and it seemed to have become their standard, and now they're moving on to ESP blocks. So clearly in their practice, there seems to be room for it, but I'm not sure that in most institutions there's a huge benefit.
Yeah, and I'm really curious, as Danielle mentioned at the beginning, about ambulatory hips, and how much need there is going to be in that ambulatory population, because I have a feeling that we're going to be doing a lot of hips in same-day surgery, and I wonder if a single shot erector spinal block with no motor deficits whatsoever may be just the ticket to get somebody out the same day. Maybe that is that extra little push, the extra little bit of comfort that they need to get them out instead of even putting any kind of catheter in. Hard to say. There's a lot of options discussed in that area. So I'm gonna wrap up with that. We've had tremendous show today. I'm so glad you guys were on. I want to remind people that tomorrow, 3 p.m., we're going to be on again, 3 p.m. Eastern time, and Samar Naruz, Meg Rosenblatt, and Sandy Kopp are going to be the co-moderators with me, and we're working really hard to have the authors for the Best of Meeting abstracts and the Resident Travel Awards present their own posters. We're only doing the 5 posters tomorrow, so they've got more time to present and discuss, and really deep dive a little bit more into their work. But thank you again, Vishal, Danielle, Kijin. I'm so appreciative of you guys taking your time out to do this, and it's always nice to see you in person. This is second best. I'd rather see you guys in person, but at least face to face is something, and I hope we'll be back together again soon next year. So good to see you guys, and take care of yourselves.
Thanks, Raj. It was a lot of fun.
Thank you.
Bye, everybody.
Okay. Bye, everybody.